I work for a UK charity, or I should say, sorry, a charity that covers England, Wales and Northern Ireland, because the Scots have their own association. And we represent about 3,500 people with motor neuron disease in our country. We're in touch probably with about 2/3 of those. And every so often we conduct a big review to basically ask our members, what are we doing right, what are we doing wrong, and what could we be doing better? And we end up with a list of priorities. And as you can see, in 1995, when we asked those questions, more research was the #1 priority. The association should be funding more research into trying to understand the causes of the disease, as Dr. Anderson has laid out, into trying to develop better treatments for the disease. We conducted the review again in 2005, and as you can see, the priorities haven't changed that much. Although creeping up the charts, down at the bottom here at #5 is access to more clinical trials. And I think that really reflects how the world has changed within these 10 years. In 1995, really, there weren't any trials. A trial had just been conducted of a drug called Riluzole. You'll know it perhaps as Rilutech, which is now licensed. But now we're seeing more and more trials occurring on a regular basis. And of course, people with ALS are going on the internet and finding out about those trials. And quite rightly, our members are saying we want not only more research to go on, but we also want to be able to participate in clinical trials ourselves. And we, earlier this year, put together a new strategy within the MND Association for the next 6 years, which basically focuses on the priorities of our members. Now, I'm only going to talk about this one and this one because that's what I'm more interested in as the Director of Research. Now, this is Mount Everest, and you know, our vision is a world free of motor neuron disease. But our vision really is way up at the top of that mountain. In fact, it's disappearing into the clouds. It's very difficult to really comprehend how we will get there. But just like Mount Everest is the biggest mountain on a range of mountains called the Himalayas, so if we are going to reach the top of our particular mountain, of a world free of MND, we have to climb several other mountains just before we can even see the big one. And that's how we approach the way we are funding research. First of all, we've tried to bring if you like, the top of the mountain a little bit closer and said, well, maybe we can't immediately find a cure for the disease, but at least we can give people the opportunity to try to participate in therapeutic trials and more clinical research, because that's what our members are telling us. We want the chance. And if it doesn't help us, hopefully the knowledge gained may help somebody who's diagnosed next year, 5 years hence. The first of our mountains we have to scale is, as Dr. Anderson said, to understand the causes of the disease. And you know, it's a bit of a throwaway line. Our fundraisers use it. I'm a little bit embarrassed about using it. If you can find the cause, you can find the cure. Not as easy as that, but it gives you a fundamental starting point on which to base your future research. Now, we know that a lot of the answers to the questions of what causes MND are found within our genes, within the human genome. The human genome is the equivalent of, I noticed in my hotel room I have a telephone directory for, I think, the whole of Iceland, just about. Well, the human genome is the equivalent of about, in information terms, of about 400 volumes of that telephone directory. And what we are looking for, these genetic mutations Dr. Anderson spoke about, is the equivalent of a single spelling mistake somewhere within these 400 volumes. So you can imagine, very difficult to find, but we know the answer is in there. And the way we will find that answer is by doing as much research as possible and having as many samples from ALS patients as we can manage to get. And so that's one of the reasons that the Motor Neuron Disease Association a couple of years ago decided to establish a national DNA bank. I'll mention a little bit more about that later on. But we're also planning on investing more in clinical and healthcare research. Now, the peak of this particular mountain, sorry, it's a little bit difficult to read, is to improve the standards of care for people with MND or ALS. And the MND Association several years ago published a little leaflet called Standards of Care, which said, these are the standards we expect people with this disease to have in our country. And when we published it, I said, yeah, very good. Now what do we do with it? How do we make it happen? It's very difficult. You can bang the table, but in our country, when you're dealing with people in suits who are accountants, not clinicians, they want evidence that what you will do will actually make a difference. And so what we have started to do is to develop what we call clinical guidelines. We have gone out and reviewed all the evidence in certain areas like respiratory support in ALS, like nutritional management, and developed guidelines for clinicians and healthcare professionals which are based on what works and what doesn't. What we've also found is there are huge gaps in the knowledge where we just don't know what works and what doesn't. And that's where I come in. We take those questions, those problems, those gaps, we turn them into research questions, and we then commission the research to fill the gaps in the guidelines to support the standards of care for people with MND. And I'll mention a little bit, an example of that later on. But I'm going to concentrate most of the next 20 minutes or so on talking about our biomedical research strategy. What we want to do, as I mentioned earlier, is try and get more people with MND participating in clinical trials and clinical research. And within the United Kingdom, the way we're going to do that is to try and improve what we call the translational research environment. That really means trying to create the fertile ground on which clinical trials can be developed. In order to do that, we need to have the new ideas, the theories coming through from the laboratory. We need to have the right people working on ALS, and in particular, what we call the clinician scientists. Clinicians that have a very good understanding of the clinical realities of the disease, but also have the scientific knowledge to enable them to actually pull this knowledge from the lab through to the clinic. And there's a perfect example of a good clinician scientist sitting in the front row here. I just wish he was working in Britain. But you also have to have people working together as well. We can't have researchers working in isolation. And one of the reasons the Motor Neuron Disease Association organises an annual international symposium on the disease is to bring the best people from around the world together and let them share the latest knowledge and information. I always say that the best science isn't discussed in the lecture theatre, it's discussed in the bar. And for us, the important thing is to find a venue, attract people, but the venue has to have a big bar as well, because that's where the real business is done. That's where the real scientific conversations are had. So I just want to mention a little bit about our DNA bank. It's a 5-year project that's jointly funded by our charity in the United Kingdom and also by the Wellcome Trust, which is a big UK-based biomedical charity. We're aiming to collect up to 6,000 samples. The core, the key part of the collection is 1,500 sporadic ALS samples, and also 1,500 controls, usually husbands and wives, because we want people who are genetically unrelated to the person with the disease. Although from what Dr. Anderson said, in certain parts of the world, cousins marry cousins, so maybe that's not always so clear. A sample, a DNA sample, is only as useful as the clinical information that accompanies it. So we are collecting very detailed clinical histories of patients and also of the people that don't have the disease, and we're also going to be bolting on an epidemiological study. That means a questionnaire, a large questionnaire asking about lifestyle factors, about diet, about history of employment, so on and so forth. Because the chances are that most causes of sporadic ALS are a combination of a genetic predisposition and also an environmental, or a number of environmental factors, perhaps occurring over 50 years. The way I often think about it is, imagine a set of old-fashioned balancing scales that you used to see in a chemist's shop, and something has to tilt the balance in favour of the disease occurring. Well, with the hereditary forms of the disease, it's like there's a fairly large weight on the scales. Given enough time, the scales will tilt. But in sporadic MND, it's more like grains of sand on the scales. So you could have a genetic factor that predisposes you. A grain of sand is on the scales, but the scales don't move. It's not enough to cause the disease on its own. So perhaps you inherit a number of genetic factors, have a number of grains of sand on the scales, they still don't move. So you have to go and look at environmental factors. Perhaps, now I'm making these up now, perhaps you were dropped on your head as a baby. Could be another grain of sand. Between the ages of 5 and 10, you lived in the countryside and the farmer was spraying pesticides over his crops every summer. Could be another grain of sand. When you were a teenager, you played a lot of sport, a lot of football, running. Could be another grain of sand. You went off to university and you drank like a fish, you smoked like a chimney. Could be another grain of sand. It is the combination of all these unassociated factors, perhaps, that finally tilts the balance and causes the disease to occur. So that's why we're trying to collect as many samples and as much information together, because it's collecting it all at the same time that will really give us the answer. But the key thing about this DNA bank is that we're going to make it available to researchers all over the world. Certainly by 2012, in fact by 2028, we expect the DNA bank to be regularly supplying samples and the clinical information to genetic researchers all over the world, and we'll be able to show then that our samples have made a difference to understanding the disease process. We also, because setting this up is quite expensive, it's costing us about £1.5 million, we're also trying to find ways in which other people, such as the government in the United Kingdom, will continue to support this. And indeed, we're just about to use the first samples in a big international collaboration, which is called a whole genome scan, which is basically, remember I mentioned the telephone directory analogy. What this will do is actually narrow the search down from 400 volumes of the telephone directory to maybe a few pages, where we think the hotspots are, where we think these genes that are associated with motor neuron disease are believed to lie. I briefly just want to mention our clinical and healthcare research as well. I mentioned that we have developed these clinical guidelines. Two of them we've taken forward to identify the gaps where we need to do research. And those are nutritional support and respiratory management. And we're just about to advertise a grant scheme to allow more of that research to be conducted. Before we got to that point, we went out and we spoke to the international research community, and we said, okay, here are the guidelines, here are the gaps, which ones do you think we should work on first? And of course, we got back a list of their priorities, but we wanted also to check that the priorities of the people that work in the universities are actually the same as the people with MND. We also did a similar exercise with our members, and that then gave us the priorities for funding. And first of all, we're looking at funding what's called a prospective study, which is actually following people with the disease all the way from the point of diagnosis, to try and identify where the problems in care and support lie, with things like nutritional support, respiratory management, to identify the best ways of spotting it, and indeed, if possible, of predicting what's going to happen in advance. Because if you can do that, then theoretically at least you may be able to prevent problems happening later on that could be preventable. We want to have a look at non-invasive ventilation, particularly at the point where people decide, well, do I want to continue with non-invasive ventilation or not? And we're also planning on conducting a trial of airway clearance or cough assist techniques. Some of you may be familiar with these. You can have machines that can help clear the secretions out of the airways. You can have certain mechanical techniques as well that carers can use. There have been cases where over-enthusiastic carers have actually broken a rib. But we just don't know which one of these techniques works best. And if we can work that out, then we can pull those into the clinical guidelines to help clinicians and healthcare professionals provide the best support. The core reason for funding this sort of research is that it should make a difference to people with motor neuron disease, either at local level or indeed, as we are increasingly trying to do, to impact on national policy and national practice. And as I said, you know, it's about really improving the standards of care, the quality of life for patients. But some of these techniques, some of this research will undoubtedly have a significant impact on survival as well. And this is just an example. Like in all cookery programs on the television, they always say, here's one we prepared earlier. This is a study that was published earlier this year that we funded on the issue of non-invasive ventilation. Now, in the United Kingdom, perhaps half to two-thirds of people with MND could benefit from non-invasive ventilation, but less than 5% of them actually receive it. Now, one of the reasons is that it costs money to provide the equipment, to provide the support, and the government says, no, we're not going to fund it unless you prove it works. The second reason was that many neurologists in Britain didn't actually like to refer their patients to the respiratory physician because they weren't sure. There was evidence that this non-invasive ventilation actually extended survival, but it doesn't stop the disease. So does quantity of life equate, is it the same as quality of life? They weren't sure that they were doing the good thing, that they may actually be prolonging suffering. And the only way to obtain really hard evidence is to conduct a little bit like a clinical drugs trial, something called a randomized controlled trial. So we funded the world's first randomized controlled trial in non-invasive ventilation, and it showed quite clearly that non-invasive ventilation not only extends survival by about 7 months in people with good bulb or good swallowing function, but it also improved and it sustained their quality of life throughout that period. So now that we have this evidence, we can use this as a big stick to start to beat up our Department of Health, to say to them, why isn't this being made available to more people with the disease? So moving on to the biomedical research, the peak of that particular mountain, as I said, we want to climb, is to get more trials being conducted in motor neuron disease, particularly in the United Kingdom and Europe. Because we can all go on the internet, we can all see a lot of trials that are being done, mainly small trials. They all seem to be happening in North America. Why is that? That's because they've already got the network established. They also have a lot more money as well, it has to be said. But there's no reason why in this country we can't, or sorry, in this continent, we can't also have a number of trials, almost like a production line of drugs to test out one after the other. Now that model looks nice and clear, doesn't it? You know, nice, sharp strategy to follow. In reality, it probably looks a little bit more like this. It's a bit of a jumble of different bricks. And you might have the background knowledge of the disease, you might have the mouse models to test the disease in, we might have established all our researchers working together to conduct large clinical trials. You've got people that know how to do clinical trials in motor neuron disease. We've got the money, we've got the trial design. If we can't diagnose the disease earlier, perhaps we're giving the drug too late. I don't know what it's like in Iceland, but in the United Kingdom, it still takes about 12 months from onset of symptoms to diagnosis of the disease. Now, common sense dictates the sooner a person is given a treatment, the more effective it's going to be. So we need to work on all of these, and if we don't have all the pieces sufficiently in place, cemented together, then there's a danger the whole strategy could come tumbling down. So I'm just going to take you through the sort of very simple process whereby you try and develop a translational research program, how you take knowledge from the lab to the clinic. With MND, of course, we need to understand the causes of the disease. If you can understand the causes, then you can start to look at the different mechanisms. You can also develop models of the disease in the laboratory, nerve cells grown in a dish, or, for example, these little guys are becoming increasingly popular. These are little nematode worms that can reach, a millimetre in length perhaps, but you can actually mimic motor neuron disease in these animals. And the beauty of these models is that you can conduct what's called high-throughput screening. You can screen thousands, tens of thousands of different drugs to see if they will protect these models from degenerating. If you get something that works in these very simple models, you can move up to the mammalian models, the mouse models of the disease. Good results would mean that there would be the confidence to take this forward to the clinic, and then of course, if it works in the clinic, get it licensed, make it available to everybody. So that looks nice and simple, but of course with motor neuron disease, we have a number of problems that we still have to overcome. The first one is, we don't know the cause of more than 95% of cases, which really doesn't give us a good starting point for this whole program. We have identified a key cause, SOD1. A huge amount of work has been done on that. It really has revolutionized the world of MND research, but it's a mechanism of motor neuron degeneration. And the problem is, we don't know if it is simply a mechanism or if it is the mechanism. Is it representative of 2% of cases, 20% of cases? 100% of cases. We just don't know at the moment. But it's SOD1 that's really being used at the moment for nearly all of the models of motor neuron disease in the laboratory. So the question is this actually representative? If it works in a SOD1 mouse, perhaps that means it will only work in SOD1 patients, not in all patients. We also have a problem in that when a researcher, let's say in America, tries a drug in a SOD1 mouse and sees an effect, then a researcher in Europe thinks, right, I'll try exactly the same thing, same mice, same drug, and they see no effect. There are very, very inconsistent results. And I think that's because we treat SOD1 mice a little bit simplistically, as if every single mouse will develop the disease at the same time, in the same way. And we're beginning to understand that there are a lot more variables. These mice are a little bit like people. They don't develop it in exactly the same way. And so we're trying to improve the standards by which researchers conduct these, you could call them clinical trials in mice. With clinical trials, of course, as I mentioned, because we can't diagnose the disease particularly quickly, perhaps many drugs that don't show an effect in clinical trials might actually show an effect if they could be given a little bit earlier. Dr. Anderson, right towards the end of his talk, showed some evidence that Riletec works more effectively than the clinical trials ever showed, because the clinical trials were carried out on people who had been diagnosed for at least 6 months, whereas now it's being given at the point of diagnosis. So just that 6-month period can make a big difference on the effectiveness of the drug. And of course, with licensing, MND is a rare disease. We have to convince the pharmaceutical companies, the biotechnology companies, that this is indeed a viable market. But, you know, that's the downside. I think it's a very exciting time in MND research because certain planets are aligning, certain events are happening. New genes are going to be identified in the next few years. We'll be able to develop new models of the disease, be it cells, be it these little worms, be it mice. And if we have different causes, we can cross-reference these causes and try and find out what are the pivotal mechanisms, what are the key events that determine whether a motor neuron lives or dies. Because if we can identify those, then we have a strategy which may be effective for all forms of the disease and not just SOD1, for example. The screening technology is advancing. There are now robotic mechanisms to allow testing of hundreds of thousands of drugs. I have a colleague over in the United Kingdom who works on new variant CJD, mad cow disease, basically. And as you can imagine, there's a lot of money thrown into that. We call it a political disease in the United Kingdom, because although only about 140 people in total have ever developed the disease, the government has thrown millions and millions of pounds into it. Well, they are now in a position, because they have a good laboratory model, a good way of testing the drug in a little dish. They are about to test 1.5 million different drugs in this high throughput system. Now, there's probably something in there that will have an effect. And the government is putting the money in. The world's biggest drug company, GlaxoSmithKline, is making all of their drugs available free of charge, and they're going to conduct this study. Now, I would like to see us, in a few years' time, being able to say, yes, we have cellular models that we know represent all forms of the disease, and then I can go to the drug company and say, right, give us your drugs. I can go to the government and say, give us your money. We want to do the same. And I do believe that's possible. We can't do it ourselves. We have to work together with other organizations. And Other ALS organisations, particularly the ones in North America, ALSA and the ALS Therapy Development Foundation, have established this translational emphasis. Okay, we've learned more about the disease, now let's move it forward and try and develop treatments. Within the United Kingdom, our Department of Health, our government department, has recently just developed a new strategy called Best Research for Best Health. And the bottom line, the important thing about this strategy is it says, we are committing ourselves to getting more patients taking part in more trials, which is exactly what I want to hear, working for the Patient Association. The first part of that is a network of hospitals has been established to focus on dementia and neurodegenerative disease. Now, this is an example of how a patient association can have an impact on government, because initially this was just going to be for Alzheimer's disease. And then we got in to see the health secretary. And the health secretary said, what do you want? And we said, we want a network. One has been working for cancer for many years in Britain, and the number of trials increased dramatically because the hospitals were all working together, government was putting money in. We want something for motor neuron disease. So the health secretary said, okay, we've got one, we're setting up for Alzheimer's, why don't we include motor neuron disease, Parkinson's disease, and Huntington's disease in there as well. And the senior civil servant, the minister's assistant, just about fainted, because he said, it's all ready to go. You know, we've spent 2 years developing this. And the health secretary said, well, I made the decision, didn't I? Yes, so I can change my mind, can't I? And now we have this new network, and it's just being established, and there's quite a bit of resource now going into the 3 main ALS MND clinics in London, Birmingham, and Sheffield. In addition to that, we have another government funding body called the Medical Research Council. They have about £500 million a year to give out. For the first time ever, they have given money to fund a clinical trial in motor neuron disease, something called MND Alliance. That's the European Minocycline Study in ALS, which includes researchers from the United Kingdom, from France, from Belgium, I think. There might be another couple of countries as well. So here for the first time we've got the government putting money into the clinic and also into actual clinical trials. We're also woefully short, I'm sure it's the same in many of the Nordic countries, of these specialist clinician scientists who know how to carry out good clinical research in motor neuron disease. And so we're going to focus on their career development. The MND Association, of course, has to do a little bit more itself. We have a care centres network that we're going to put more research, money into, and we're also going to put a lot more money into research. We've just established a new initiative called the MND Association Research Foundation, and we intend to increase our research spend from the current £1 million a year up to at least £2.5 million a year in the next couple of years. What are we going to focus on? We're going to focus on MND. As I said, identifying the causes and developing models is very important. We need to make sure that the research always links into the clinical nature of the disease, and also, of course, what is the translational potential? This knowledge that's being gained in the lab, how will it be able to move through to the clinic? We need to develop the research infrastructure, these research networks, the clinician scientists in particular, and also for trials like this minocycline trial, we're actually going to bolt on another study, which is taking cerebrospinal fluid samples from patients and conducting proteomic studies to try and identify markers of the disease, which can be used as aids to diagnosis. And this is an international collaboration. You cannot do these things in isolation. So we have to develop our influencing capacity with the major funding bodies in the UK and beyond, and also with the drug companies to get them more interested in this disease. We have a number of outcomes. I'll just skip through this, so that by 2012 we'll be able to say, yes, we have moved things on from here to here, we have spent our money wisely. However, before I get lost in my own hype, I don't know if you can see the punchline at the bottom. This is Lawrence. He's in his laboratory, he's turned himself into a fly, and his wife is at the top of the stairs saying, lunch is ready, Lawrence, and what, you're still a fly? You know, as Lawrence is finding out here, there aren't any quick fixes. That's the nature of research. It's a long, slow process of trial and error, of hypothesis and experimentation. We do have a mountain to climb, but you know, I do believe that we have now a route up that mountain. It's not an easy route, but I think given time and effort and teamwork, we can get there. So I look forward to seeing you all at the top. Oh, thank you very much.